Dear Frank, dear Bo, thank you to the organizers to give me this topic, which is not easy. And I will try to make it as practical as possible. So I want to focus only on Crohn's disease, because otherwise it would be too confusing. I want to tell you how you assess mild Crohn's disease versus moderate or severe disease. I want to show you treatment algorithms for patients with mild ileocolonic and mild colonic Crohn's disease. And at the end, I want to try to answer the question, can we predict the future disease course of a patient based on an initial presentation with mild disease? So what are we assessing? The current disease status as mild, or do we assess a disease severity and need for immunosuppressive therapy in the past, if this is a patient already known to us? Do we assess the future disease course as mild? Can we say you will have a mild disease course and that's why we do this X and Z? The overall impact of disease on the patient, I think, is important to assess, and it could be very mild, but the severe or the disease already very severe if you look at damage, structural damage. And that's another thing you can assess, structural damage in a patient with mild disease. Or you can just look at laboratory parameters. Is this reliable? Can we just rely on CRP and forget the rest? Or should we combine structural damage and laboratory parameters? I'm afraid I can't give you really a lot of answers to these questions. I will try. First of all, how you assess the current disease status. And I think the best definition I found was in the European Guideline for Crohn's disease, published in 2010, that you can define mild, moderate, and severe disease according to CDI, which we normally don't do, the Crohn's Disease Activity Index. We don't do this in clinical practice, but we consider a CDI of 150 to 220 as mild. And what does it mean? The patient is ambulatory, he's able to normally eat and drink, he has less than 10% weight loss, he has no features of obstruction, he might have some diarrhea and some abdominal pain, but no feature of obstruction, no fever, no signs of dehydration, no abdominal mass or tenderness. And the CRP is usually not increased or just slightly above the upper limit. This is in contrast to moderate disease, which is equivalent to 220 to 450 CDI. And this patient has a weight loss of more than 10% in the last 3 months. He might have intermittent vomiting. He has more tender mass. There's more warning signs on physical exam. He has recurrent obstructive symptoms, for example, or signs of dehydration. And the CRP in these type of patients is always elevated. And then there's a severe Crohn's disease, which we all know. You have you're cachectic, you have significant weight loss, 20 to 30%. You have an obstruction or an abscess. You have persistent symptoms despite intensive therapy. And the CRP is always increased in this patient. So that is how we assess current disease status, but not future and not past disease status. You can look as well at the past. And there are good studies, population-based studies in Olmsted County, in England, and in Denmark, who showed that in patients with Crohn's disease, 57% had no steroids in Olmsted County over a time period of 23 years. They never had steroids, but they didn't have azathioprine either or anti-TNF. So they were probably maintained on nothing or 5-ASA, which we know, according to our current guidelines, is not recommended anymore. But these are proven data. In England, this is about 25% of the patients who never saw steroids for a time period of 5 years after the initial diagnosis. In Denmark, this is about 44% of patients. Then you can look as well how they responded to their first therapy, and can perhaps there define this was more mild versus moderate severe. And again, this is data from Olmsted County, England, in Edinburgh and Copenhagen, population-based. These are patients with the first diagnosis of Crohn's disease, and they got their first steroid taper. And after 1 year, about 39 to 44% were in remission and off steroids. Is this mild disease? Probably. They were not on azathioprine. But 2/3 of the patients were steroid dependent or steroid refractory and needed surgeries. So this is clearly more moderate to severe disease. And then you can define it according to the bowel symptoms of the patient. This is a cohort study, the Ibsen study, published in 2007, and they looked at different bowel patterns reported by the patient. And I associated this now with disease types. They don't really do this in the paper, but mild disease is probably the one here in curve 1, where you have initial symptoms and then you're like very mild symptoms over the next 10 years. That was one part of the patients. And I don't think this is mild disease, but that's a problem. These are patients with mild symptoms, but after that, after a certain time period, this could be 3 to 4 years, they suddenly develop severe symptoms and then they have severe complications. That's probably not mild disease. And then you have, of course, moderate to severe Crohn's disease, and that's much more easy to define with the symptoms. Here you have two curves, curve 3 and curve 4. These are chronic continuous bowel symptoms or chronic relapsing bowel symptoms. And I think that's more easy to recognize. I think the main problem is this patient with very mild disease, which later on develops severe disease. And if you want, a problem is, well, this patient who has initially significant symptoms, but somehow very fast we get them in remission and then they're doing well. The question is, this was all before anti-TNF therapy. So these are a patient with steroid-induced remission. So I want to illustrate the problem in total of 3 case studies. This is the first case, a 40-year-old male patient with abdominal pain-associated diarrhea, which he had for his whole life. So he's 48 now. But it was worse over the past years, and is 3 to 4 times a day. He has a normal CBC and CRP. He didn't lose any weight. He underwent then colonoscopy, which showed ileitis, and he had a normal colon. The pathology confirmed Crohn's disease with focal erosion and a granuloma, and the CT enterography showed as well a thickened terminal ileum. Here you see the colonoscopy. There was some erythema, some edema, and these focal ulcerations. The second case is a 60-year-old male patient who presented to me for a screening colonoscopy. I looked up his history, and it said he had a hep C infection and is currently in sustained virologic response after antiviral therapy 2 years ago. And he has as well a history of ileocecal resection for Crohn's disease 15 years ago. He had no postoperative therapy. And the last colonoscopy, according to him and according to the chart which I looked up, showed some inflammation at the anastomosis in the small bowel. We assume that was moderate at that time point. But nobody did anything, the patient went home. That was 5 years ago, and I looked as well before the colonoscopy, no signs of anemia, the CRP was slightly above the upper normal limit, again, no weight loss. And if you look at the colonoscopy, you see the anastomosis, it's narrowed, it's ulcerated, it's inflamed. That is probably a Rutgers score of I3. If you want to really say that's narrowed, it's probably a direction of I4. And again, if you looked at the old colonoscopy report, it didn't seem to have changed since 5 years on no therapy. So what is the treatment algorithm for mild ileocecal Crohn's disease, what we consider mild? If you have mild symptoms and mild to moderate endoscopic activity, and this combination assumes that you can't have severe activity and have only mild symptoms, then you start the patient normally on budesonide in ileocecal Crohn's disease. If you have mild symptoms and you fail budesonide, then you should step up to the steroid taper. Again, then there's no recommendation, and this is based on the newest Crohn's disease guidelines from the European, or from the ECHO. Then there's no recommendation for continuation of any type of therapy. You just do a steroid taper. If the patient then needs more than 2 steroid taper in a year or has recurrent mild symptoms with confirmed mild to moderate endoscopic activity, then you start azathioprine or you choose an anti-TNF therapy plus minus an immunomodulator. Important is in the lower area here, you have to continuously reevaluate the patient for clinical activity. You can't send him home on a budesonide taper and say, see me back in 1 year. I think this is a patient you should probably see every 3 to 6 months, at least initially, to make sure that this stays a mild disease course. Why should we choose budesonide over steroids? These are all data from a total of 4 trials. There's as well a meta-analysis, but I prefer to show you the single data of each trial. Here on the left side, you see steroids. There were 2 preparations. One is the Entocort, which we know, which is available in the United States. The other one is called Budenoforc, which is just available in Europe. It's pH-controlled release. Overall, you see the steroids are slightly superior inducing remission in patients with ileocolonic Crohn's disease compared to budesonide, but overall there was no significance in each of the trial comparing steroids with budesonide. However, there was significant less adverse event steroid specific in budesonide compared to the steroids. That's why it should be the preferred treatment in mild ileocolonic Crohn's disease in patients who don't have extraintestinal manifestation. It's very important. A patient who has severe extraintestinal arthralgias or arthritis is probably not responding so well to budesonide. You should consider earlier steroids. What's about early therapy, azathioprine therapy in these patients? And we saw this slide in the past already. The RAPID trial was shown several times at this meeting. And these were not patients with mild disease. These were actually patients who had risk factors for disabling disease. So they were younger than 40 years or had active perianal lesions, or they had steroid use within 3 months of diagnosis. And they were started on early azathioprine or on conventional management means step-up approach. We do 2 steroid taper and then we start azathioprine. And you see here, this is a group with early azathioprine. Of course, everybody is on it. And here you see the proportion of patients on azathioprine. And about after 3 years, 60% were on azathioprine. And what did this show in sense of clinical remission? There was no difference. What we can take home from this study is that you can start later azathioprine. You don't lose anything. You have time. You can treat the patient first with Entocort, budesonide, or with a steroid taper. If he then has recurrent symptoms, you can still start azathioprine. On the long run, it doesn't make any difference. Already after 12 months, there's no difference anymore in between both groups. We look at the outcome. The patient with the mild Crohn's ileitis, which I showed you at the beginning, he was started on budesonide, had some improvement of symptoms, but not really, had persistent CRP, and then he underwent a steroid taper, and because he had this persistent problems of budesonide already, we knew he needs a maintenance therapy and was then started on azathioprine and is since then in remission. The case 2 is a little bit different. So again, he had no therapy for 15 years after surgery, and he had an endoscopic recurrence 5 years ago, which looked similar like now. What kind of patient is this? And we have to look a little bit back at the natural course after ileocecal resection, and there's a good single-center study with about 139 patients, and only 25% of them were on either azathioprine and 6-MP, or 6% were on anti-TNF. Again, this was between 1980 and 2000. All patients who were on this immunosuppression were probably started not immediately after surgery, but slightly later. And if you look up after 10 years, our patient is 15, the recurrence rate, clinical recurrence rate was about 50%, but the other 50% were doing well. And if you looked at the concomitant medication in this group, it didn't really matter if the patient were on azathioprine or anti-TNF. They had similar recurrence rates. If at all, the azathioprine, the anti-TNF group, had more recurrences, but I think that's the retrospective bias of the study. And if you looked at surgeries, again, 35% had need for another surgery after 10 years, but 75% had not, and again, the therapy didn't matter. And I think we have to see this patient more in this context. He's already 15 years out after the surgery without any therapy, so he doesn't fit in any guideline. What I discussed with the patient, we should at least try budesonide and see if he feels better. Perhaps he doesn't even know that he feels bad. And we tried this for 12 weeks, 9 milligram, and he claimed he didn't feel better or worse. He was doing fine. He preferred to stay off therapy. And 1 year after I saw him first, I followed him up, and he's still in clinical remission. We plan, after 2 years, another colonoscopy. This is the last case, the case number 3, which illustrates our difficulties. This is a 40-year-old female with a history of multiple sclerosis. She had in November 2014 a new onset of generalized abdominal pain, normal bowel frequency. She was then underwent a colonoscopy, which showed 4 larger, it was described like this. We didn't perform the colonoscopy. It was 4 larger colonic ulcers, but they were scattered throughout the colon, these 4 single ulcers. The pathology showed chronic active colitis, and she was started on mesalamine 2.4 gram, and the abdominal pain improved. In August 2015, she underwent then a second colonoscopy check for mucosal healing, and from 4, she went to 2 large, what they called large solitary ulcers. So overall, an improvement. and a few small other scattered erosions. The pathology, interestingly, didn't show any inflammation, and then she was sent to us for a second opinion, and she did very well. She didn't have any complaints. She was still on mesalamine 4.8 gram, had regular bowel movements. Interestingly, she was treated as well with fingolimab, which is a S1P1 inhibitor for multiple sclerosis. And we think that this probably works as well in Crohn's disease. Ozanimod is currently tested for ulcerative colitis and had promising results in ulcerative colitis and is as well tested in Crohn's disease. She had no weight loss, normal CBC, CRP. So that's all she qualified for mild Crohn's disease at the time point of presentation. And we said, you call us back immediately if you have any symptoms, otherwise we do another colonoscopy after 10 to 12 months. So what's the treatment algorithm for mild chronic Crohn's disease? If you have no symptoms and mild endoscopic activity, you do no therapy or sulfasalazine, and probably methylamine is as well an option, but it's not very well investigated. If you have mild symptoms and mild endoscopic activities, you can start a steroid taper or perhaps budesonide MMX. That's not in the guidelines because it was mainly tested for ulcerative colitis. If you have recurring mild symptoms and mild to moderate endoscopic activity, especially if the endoscopic activity is more extensive, I think you should start immediately the patient on immunomodulator, again in a step-up approach. And if the patient still has mild symptoms or has moderate severe endoscopic activity, which I think doesn't correlate well in colonic Crohn's disease, you have at least some symptoms if you have severe endoscopic activity, then you can start an anti-TNF therapy. Again, very important, the continuous re-evaluation of activity. So what's the outcome of this one patient? 10 months later, she calls us with new onset of diarrhea. A CT enterography shows isolated colonic inflammation in several segments, and the colonoscopy shows severe colitis with an inflammatory stricture which we cannot pass in the descending colon with a pediatric colonoscope. She has about 8 bowel movements a day. She has a weight loss about 10%. So from a mild, she went at least to moderate endoscopically to a severe Crohn's colitis. So this is the problem we face. How do we evaluate mild Crohn's disease, and how do we exclude that patient from mild symptoms going 11 months to moderate symptoms and severe structural damage? The problem is that we have no uniform definition for a severe disease course which can or cannot develop despite initial mild presentation. We have several identified factors which none of them was present in the patient. These are sustained disabling symptoms and impaired quality of life, repeated flare-ups, hospitalizations, development of irreversible penetrating or stricture lesions, need for repeated course of steroids, need for surgery on elevated CRP in clinical remission. None of this was present, and the problem is that the individual accuracy of each of these is not very good. So this led me to conclude that what Lloyd Mayer always said, that no clinical trial and no clinical presentation ever presented in papers completely reflects what's happening in an individualized patient. And it's really very difficult to follow this patient's mild Crohn's disease, and you have to be very vigilant. So I want to sum up that mild Crohn's disease is treated with a classical step-up approach, not with a top-down approach. We do a classical step-up. Early start of immunosuppression is not warranted after a diagnosis of currently mild Crohn's disease. However, frequent clinical re-evaluations are mandatory, as you see in the last case. And so far, there are no reliable indices or markers who prognosticate the future course of disease in an individual patient. In a cohort of patients we can, but not in an individual patient. Thank you very much.